Hi, I'm Dr. Romain Bourcier. I'm a French neuroradiologist and I'm working in the University Hospital of Nantes. And today it's a great pleasure for me to welcome Dr. Laura van der Kamp, who's working about the risk of rupture for growing aneurysm. So, hi, Laura, could you please introduce yourself?
Hi, I'm Laura van der Kamp. I'm a medical doctor and I finished medical school at the Utrecht University. I did several research projects during medical school, and after my graduation in 2020, I started as a PhD student at the Department of Neurology and Neurosurgery of the University Medical Center Utrecht. My PhD focuses on the risk of rupture and growth in intracranial and ruptured aneurysms. My first article is about the risk of rupture after aneurysm growth. That is the study that I will present at the conference.
Okay, thank you, Laura. Could you make more precision about the aim of your study? What is the end point?
Yes, of course. The study aimed to determine the absolute risk of rupture for patients with a growing aneurysm. Previous studies showed that a growing aneurysm has an increased risk of rupture. These studies provided a relative risk of 12 up to 36 compared to non-growing aneurysms. However, the absolute risk was unknown, and these risks are needed to weigh against the risk of treatment complications. So therefore, we aim to determine the absolute risk, and moreover, we aim to also provide individualized risk of rupture by a prediction model.
Okay, thank you. And do you know how the ICA growth was recorded in your study? I mean, was it by CT, MRI? Because I guess there are different cohorts included in your study. Could you make it clear, please?
Yeah, that's an important question. So for consistency over the cohorts and to be comparable to future research, we use the definition of growth of 1 millimeter as suggested by the NIH Common Data Element Project on Unruptured Intracranial Aneurysms and Subarachnoid Hemorrhage. This is a consensus between aneurysm experts. So the radiologist or neuroradiologist measured the aneurysm size on a 0.1 millimeter scale on TOF MRA, CTA, or DSA, but we have no information on MR sequences or strength fields of the different cohorts.
Okay, thank you. And how was conducted the follow-up of included patients? And overall, what was the duration of follow-up for included patients in your study?
Yeah, the patients were included at the moment growth was detected at follow-up imaging. So that was our baseline. After growth, the patients were followed until aneurysm rupture, aneurysm treatment, or last patient contact. So patients with a short follow-up duration due to treatment decisions, as well as patients with a longer follow-up duration were included. Only patients with a follow-up less than 1 day, for example, because the detection of growth and the treatment was scheduled on the same day, were excluded. The median follow-up duration was 1.3 years. The interquartile range of the follow-up was 0.4 up to 4.0 years. Due to the observational design of the study, as I said, treatment decisions were made during follow-up, and these were unavoidable and shortened the follow-up durations of these aneurysms that underwent preventive treatment. So the follow-up duration of the treated and ruptured aneurysms was logically shorter than the follow-up duration of aneurysms that were still followed with imaging of the detection of growth.
Okay, great. And how many patients you include?
We included 312 patients with 329 growing aneurysms. But for this study, we screened almost 5,000 patients in 15 international cohorts.
Okay, that's huge. Great study. And so the big question, how many rupture events in the timeline considered? How many rupture aneurysms?
Thank you for the great question. Yeah, 25 aneurysms of the 329 aneurysms ruptured during follow-up. The absolute risk of rupture is 2.9% at 6 months, 4.3% at 1 year, and 6.0% at 2 years after growth. If you look at the risk of rupture per month, the risk of rupture declines over time after growth.
Okay, so I guess you ran an analysis of predictors of rupture in this population. So what was the statistical strategy applied in your study to determine this predictor of rupture?
Yeah, thanks. We indeed did some analysis for the predictors, and we included all potential predictors that are already known in the literature in our full prediction model. Potential predictors of rupture were age, sex, previous subarachnoid hemorrhage, smoking, geographic region, growth factor, aneurysm size, shape, and size. The full model was simplified by exclusion of potential predictors with a backward selection procedure based on a p-value less than 0.20. In additional analysis, we built a prediction model. ESOC's proportional hazard models are known to overestimate the predicted risk when applying to the model to new patients. Shrinkage was applied using ridge regression. The amount of shrinkage was based on the full model with all potential predictors, which I mentioned before. The regression coefficients from this analysis were used to estimate the 6-month, 1-year, and 2-year risk of rupture in our final prediction model. And the discriminative ability of the model was 0.72.
Okay, so the results, did you find any independent predictors of rupture in this population?
Yeah, the selected predictors were aneurysm size, aneurysm shape, and aneurysm size. And the independent predictors of rupture are size and shape. So a size equal or larger than 7 millimeter, an irregular shape, and a location other than the internal carotid artery increases the risk of rupture after growth. Therefore, the final prediction model was called the triple S prediction model, referring to aneurysm size, shape, and size. And with this model, you can estimate the risk of rupture after growth for future patients.
Okay, so to summarize, what are the main assets of your study from your point of view? What are the main assets?
And thank you for the question. So we included patients from low and high risk populations from 7 countries of 3 continents, and that adds to the generalizability of the results. As I said, we developed the triple S prediction model to provide patient-specific absolute risks of rupture after growth of an aneurysm. These absolute risks are directly relevant when you're discussing the pros and cons of preventive treatment after aneurysm growth with your patients. So that are the main assets of the study.
Okay, thank you. That's great. And do you see any other relevant variables to include in your model in order to improve the prediction score?
Thank you for the nice question. Yeah, for this study, we assessed the potential impact of predictors based on predictors that were already well described in the literature. But I'm eager to find new predictors that could play a role in predicting rupture or growth. For example, I'm thinking of aneurysm wall enhancement. I'm currently working on a UCAN study about the predictive value of aneurysm wall enhancement, and I'm looking forward to new collaborations. In my opinion, these multi-center studies on predicting instability are important to help future patients. Therefore, I want to end by thanking all co-investigators for their work and trust in the presented study. They made this multi-center study on the risk of rupture after growth possible.
Thank you, Laura. It's a great study. I can't wait to read it in a high-impact journal, and thank you so much and congratulations.
Thank you.
Goodbye.